So we're now going to move to Philipp Lurz from Leipzig, and Philipp is going to present another patient for us. On this occasion, a patient with secondary mitral regurgitation and its associated pathophysiology. Philipp.
Yes, thank you, Benna. So as you've just heard, the second case will be an implant in a patient with functional mitral regurgitation. That case certainly has some complexity to it. It involves several different approaches to grasping, and we will discuss that throughout. This was a 75-year-old woman who presented in NYHA class 3. She had peripheral edema, and she just recently was again hospitalized for acute heart failure. Her main diagnosis was HFrEF. Here you see her medication, which is pretty much according to guideline-directed medical therapy in a patient with reduced left ventricular ejection fraction. ECG showed AFib, coronary angiograms with some atherosclerosis but no significant stenosis, and then the echocardiographic assessment, left ventricular ejection fraction reduced 38%, also reduced right ventricular ejection fraction, and some increase in pulmonary artery pressures. Her risk scores, as demonstrated here, were certainly high, and therefore the decision in the heart team was that this patient is best treated by a transcatheter approach. Now we start off with the specifics, with the anatomical and hemodynamic specifics. Here on echo you see again left ventricular ejection fraction is reduced. There is severe mitral regurgitation. On this 3D echo reconstruction you can see that there are two more dominant coaptation defects. One is more central, and then the other one is more to the lateral aspect. On this long axis view you can see that this is clearly functional. There's a lot of tension on the secondary cords of the anterior leaflet and some pseudoprolapse of the anterior leaflet. And you can also see that the resulting MR jet is a little bit eccentric. So again, there are two defined coaptation defects, one in the more central portion of the valve, and then the second one at the lateral aspect of it. What's important to mention here is that the overall mitral valve opening area was just a bit more than 4 square centimeters. So this is important when we decide on a strategy whether we should go for 1 or 2 devices with that size valve. You would normally think that that valve could only accommodate 1 device. So we were still about to come up with a strategy. We have 2 clear jets, 2 lesions, but a valve area which allows probably or maybe to implant only 1 device. And we decided that the lateral jet is the predominant one, and therefore the strategy to start off with was to implant 1 device in the larger lateral jet. On the right-hand side, you can see the 3D reconstruction from a left ventricular point of view, which sometimes is quite helpful, especially later on when you'd like to judge the degree of residual MR. But we mainly base our strategy on a view from the left atrium. The procedure, as always, when we treat mitral regurgitation, starts off with a transeptal puncture. This is pretty much what similar to what you're used to from other techniques and devices. You aim for a posterior position, and in terms of height between 4 to 4.5 centimeters. Again, you see the 3 components of the system: guiding catheter, the steerable catheter, which allows you to move from anterior to posterior leaflet, and then the implant catheter to steer and maneuver the pedals and the clasps. And at the very end, the actuation knob to open and close the device. So the guide is positioned into the left atrium on echocardiographic and fluoroscopic guidance. And then once the atrial septum is crossed with both the dilator and the sheath, the dilator is removed and the device can be advanced. You've seen these steps. The device is advanced into an elongated position and then closed, this will shorten the device and therefore makes it easier to maneuver it in a left atrium, especially when the left atrium is not that large. Again, these maneuvers are performed on echocardiographic and fluoroscopic guidance. The device is now fully closed and can be advanced further out of the sheath, and then the next step is to steer it down towards the mitral valve, and to do so, flex is introduced on the steerable catheter. Now that's a point during the procedure where it's certainly worth to take some time and make that very thorough. It makes the procedure much easier if you manage to get a truly perpendicular alignment of the device towards the mitral valve annulus, and this should be certified on two planes, on a commensural view on the left and also a long axis grasping view on the right. The next step, as you've seen before, will be opening of the device and then getting the clocking right. It is important to implant the device always perpendicular to the line of coaptation. This normally is at 6 to 12 o'clock, but remember, if you implant it in segment 1 or segment 3, the clocking might be different. It is important to have it always 90 degrees to the line of coaptation. Our aim here was to go to the more lateral jet, which is pretty much in the center of the valve, so we aim here for a clocking which is 6 to 12 o'clock. My preferred mode of action with this device is, if possible, is to do a simultaneous grasping, but obviously since we have the benefit of this specific feature to do staged grasping, we'd always like to have that ready, so we do a clasp checking to make sure what's the anterior and what's the posterior clasp. This is then the hardest part during the procedure, to remember which one was which, but therefore you have two operators. Okay, so we remember which clasp is anterior and which one is posterior, and then we are ready to cross the valve. Here again we use echocardiography and fluoroscopy. During this maneuver, fluoroscopy is quite helpful to make sure that the clocking stays roughly the same. It needs to be double checked that once again we are beneath the valve in the left ventricle, but as little maneuvering in the LV as possible. So the device is in a more lateral position. We go back to 3D echo to ensure that we have a appropriate clocking of the device, again perpendicular to the line of coaptation, and then we can retrieve and pull back the device, and by doing so engaging the leaflets on the pedals of the device. The aim always is, and this is important for the mechanism of this device, is that the leaflets are really touching the central part of the spacer, which is called the apex. So this is important. Both leaflets seem to be on. The device is then retracted even further. We see that there's more tension on the leaflets. All these steps can be done slowly with double checking on echo and fluoroscopy. There's no need to rush. So both leaflets are nicely on, both leaflets are touching the apex of the device, and this is the time where the clasp can be put down. Because both leaflets are nicely on, there's no need to do that independently, so we bring them both at the same time. The advantage if you bring them both at the same time is the fact that getting the clocking right is a little bit easier. If you do that independently or staged, you have to make sure that once you've grasped the one leaflet, you still have to ensure the same clocking when you grasp the second leaflet. Okay, what you see now is what we call the bouncing of the clasp, which is a good sign, meaning that there's enough tissue on. The device is then closed. We see that this applies tension to the leaflets. Again, an indicator that enough tissue is in. What we see now is that there is still mitral regurgitation at the medial aspect of the device, but also at the lateral aspect of the device. And here we come to the first poll question of this case. So what do you suggest as the next step should be. First, move more laterally and capture both leaflets simultaneously. Move more laterally and then maybe use staged grasping with capturing of anterior leaflet first and then posterior. Next option, try to optimize the result in the current location, optimize one leaflet capture and then try the other. So implying that the position is fine, but the leaflets aren't perfectly in. And then the last option, implant a second device.
So Philippe, thank you very much for your presentation. You've given a very clear description of the technicalities of the first parts of the procedure. Dr. Rui Tellez wanted to ask some specific questions. The first was in relation to the site of the atrial septal puncture. I think you did describe that, but can you reiterate that specifically? Where do you aim for?
Yes, so it is important to be in a posterior position. This is really important, maybe for this device even more so than from as compared to what we use from the MitraClip. And compared to a MitraClip procedure, we probably want to be a little bit further down with a distance to the mitral valve of 4 to 4.5 centimeters, but not more than 4.5 centimeters. Otherwise, steering gets a little bit more complicated.
Okay. And I have another question from Dr. Tellers. I want to make sure that everybody is voting on your specific questions, so please keep those responses coming so we can see your views. But also talking about steering and navigating. Occasionally we have patients, particularly small elderly ladies, with a small left atrium. Are there any tips and tricks for navigating through a small left atrial cavity before you approach the valve?
Well, I guess if you've seen the device get significantly shorter once it is closed. So you certainly should close the device first before you steer down to the valve. And then the other technique which helps is to check on echo that you withdraw the guide as much as possible, but at the same time still being in the left atrium, and that will provide you with some additional space to maneuver.
Okay, thank you for that very clear response. So in fact, you've split our participants very equally. 1/3 think that you should move laterally and capture both leaflets at the same time. Another third think you should move laterally and then do one leaflet at a time. And then a further third are split and aren't quite sure what to do. So you're the expert, Philippe. You need to tell us how you proceeded.
Yes, so maybe you go back to the case, and then you will see what we've done. Remember, with this first device, what we really wanted to do is we wanted to get rid of the lateral MR chat. So that was the aim. And what we've seen on, can we go back to the case, please? So what we've seen on echo after we closed the device and looked at the device was that there was still significant mitral regurgitation at the lateral aspect of the device. So we weren't happy with that. And therefore we decided to do that again, change the trajectory slightly and place it in a more lateral position to reduce this lateral MR chat as much as possible. So we went back into left atrium. We again made sure that we have good trajectory, meaning that the device is aligned in 90 degrees towards the mitral valve annulus in both planes. As you can see, if you've just seen it, is that we move the device back and forth a little bit to see how it will run once we advance it into the left atrium. We open it again. It's always good if you see the arms widely extended on a long axis view, as you can see here now on the left, on the right. So we are underneath the leaflets. We are now in a more lateral position. We double check on 3D, and as you can see here now, we're now aiming for a clocking which is probably more 1 to 7 o'clock rather than 6 to 12, because we moved further out into the lateral part of the valve. What we also thought we should do now is we get the anterior leaflet on first, we put the clasp down, and then grasp the posterior leaflet after the anterior leaflet. Now to do so, again, the tarsal maneuver, swinging over from anterior to posterior. What you can see here now is something we see more often, and that is that the posterior leaflet is rolling over the device, but it's not nicely on. This can happen. This device is a little bit larger. In a valve like that, you have secondary and tertiary cords, and sometimes it can be a little bit more difficult to navigate through these cords. So what can be done is, first you need to be patient, and secondly you move out of the posterior leaflet and then in again, as we've just done. And here you can see the different appearance with the posterior leaflet now not curling anymore but being nicely on, and then we bring down the clasp and close the device. So that's something which is seen more often, rolling of the posterior leaflet, but that's not a major obstacle, but something which can be overcome. Okay, so the position here was better, but still there is MR at the lateral aspect, and we thought that maybe we can do better. So what we're doing now, we see that the posterior leaflet is still quite mobile, so we now do what is referred to as single leaflet optimization. We leave the anterior leaflet where it is, nicely in. We open the device and we bring up the posterior clasp, as you can see in a second, and then trying to get even more in of the posterior leaflet, and at the same time double checking the clocking. Here you can see that the clocking was not perfect, so this is corrected for now. The device is now turned clockwise to get a better clocking. These are little changes, but they can have major effects. The clocking is adjusted. The device is moved even further into the posterior leaflet. And when we bring down the clasp now, you can see that the clasp is almost touching the annulus. So there is as much posterior leaflet in as possible. That was what we wanted to achieve. We close the device again, and then we optimistically watch the echo and hope that we are doing better now. And finally, after the third grasping attempt, we managed to achieve an acceptable reduction of the lateral MR chat. We still have mitral regurgitation medially, so next step, looking at the gradient. The gradient is 2 millimeters of mercury. To be honest, we might have expected a little bit more even here because the valve is not particularly large, but with a gradient of 2 millimeters of mercury, we felt comfortable that we should leave the device where it is, release it, because there was good MR reduction, and then as a next step, try to implant a second device, going into that still present medial MR chat. Lateral, only a small chat, but certainly a good reduction in this position. So this is now a procedure where the first device goes in a lateral position and the second one goes in medially. I guess that if we have a strategy up front where we implant two devices, we probably would normally go medially first and then laterally, but you can do either way. It's not too much shattering, and echo can help around that. Okay, the second device goes in. We were prepared at that point that if the gradient is not acceptable, we can still remove it. Everything is retrievable until the point where you release the device. Okay, this device is now supposed to go into the medial chat. What we also discussed at that point is that maybe we try to get the leaflets nicely on, but maybe not too tight, to have good MR reduction, at the same time preserve adequate opening of the leaflets and of the valve during diastole to end up with acceptable gradients. So we don't place this device exactly next to the first, but right at the position where we see the largest MR chat, and this is in slight distance to the first implant. Now we are just above this medial MR chat. The device is opened. We are ready to cross in a second. We close the device before we cross it, just to make sure that we don't get entangled into the first device. Obviously, the risk is lower when you cross the valve with the device being closed. We cross the valve, we open the device. We are still in the same position we were aiming for. We move the device already slightly into the leaflets and now opening it, double checking clocking. As you've seen, clocking is really important. These are minor adjustments which can make a difference. So the device is in the right position. The clocking is correct, which is slight change here, slight torque towards counterclock to have it really 6 to 12 o'clock. And then we go back to X-plane view. For the implant, we have the two leaflets on. Now remember, the aim here was to have the leaflets nicely on, but not pulling too hard on them to avoid the risk of a gradient which is not acceptable in the end. So both leaflets are on. When they're both nicely on, then our default approach would be simultaneous grasping. Which we will do in a second. Here, the possibility would be to retract the device even further, but we thought that that should be sufficient. Double checking on fluoroscopy. Obviously, fluoroscopy can be used even better for the second implant because the first implant provides a nice landmark for maneuvering and also to ensure clocking. The two clasps are brought down. We see again that bouncing, that up and down motion of the clasp, suggesting that sufficient tissue is on. And then we close the device. We look for some tensioning on the leaflets, which is always a good sign. And then obviously the next step was to thoroughly assess what that second implant meant for the gradient. In terms of MR reduction, we see that we certainly reduced that medial MR jet. Now we go to the gradient. When we assess gradient, it is important also to take into consideration obviously patient's heart rate and then also patient's blood pressures. When pressures are very low, we increase blood pressures to make sure that we do not underestimate the gradient. We ended here up with a gradient of 4 millimeters of mercury at systemic pressures which were equal to the ones during admission, so certainly not too low. We double check that at different orifices. You really want to make sure that you don't underestimate it. So we had 4 first, here we have 3 millimeters of mercury, which is really interesting that in a valve which is not terribly large, the two devices can be implanted to reduce MR at the same time ending up with a gradient of 3 millimeters of mercury. And in terms of MR reduction, we were happy, but remember the device is still connected to the delivery system. So next step is release of the device. And here comes the second and last poll question for this case. So in general, what do you expect? When you compare the MR result before and after release, what would you expect happens after release? MR gets worse, MR gets better, or actually stays normally the same?
So thank you, Philippe. It's a very elegant demonstration of the technique and also your very precise manipulation of the device and the very the finesse that you've demonstrated in delivering it and tensioning it and working very closely with your imaging colleague is very clear to see. While we wait for the response of this question, and we'll have to wrap up quickly after that, could you just tell us what's the median number of clasps that you're using? Is it usually a 1 clasp procedure, or is it usually a 2, or is even 3 possible in a patient with a very big annulus?
Yes, 3 is possible, especially in a very large annulus and functional MR. Our mean number of devices is 1.5. And we came to an approach where we normally question ourselves, why should that patient not receive 2 devices rather than the other way around, where you have to argue why you put in 2. So our default strategy is more or less 2 devices, but obviously we assess the gradient very carefully.
Okay, so here's the answer to our question. 75% of our participants feel that the MR reduction will improve. Is that consistent with your own feelings?
Yes, that's equal to our experience. It improves or it stays the same. It hardly ever gets worse, which is important, obviously, because once you release it, there's pretty much nothing you can do about it. Okay, so going back to the very last seconds of this case, we release the device and then I'll show you the final result. And then we are done. So release, both devices in parallel, good position, very little motion, and you can see that we achieved a good reduction of MR in this patient with 2 main jets which were quite apart from each other and with an acceptable gradient of 3.5 millimeters of mercury as mean. Thank you.
Philippe, that's an outstanding result. If we were in a main arena with a packed Congress, you'd have a huge round of applause for that procedure. So thank you very much indeed.